Greetings, everyone. Thank you for joining us today. You have joined us as part of the Robert Wood Johnson Foundation's Systems for Action Research Program, our Research in Progress webinar series. We're glad you're with us today. We've got a great webinar all teed up for you today. Let me start by introducing myself. I'm Glenn Mays. I'm a professor of health policy and management here at University of Kentucky, and I lead the Systems for Action Research Program National Program Office for the Foundation. And this is a regular seminar series that we do with research projects that are underway as part of the Foundation's new Systems for Action Research Program. We're very pleased to hear from one of our newly funded projects today, examining issues around housing for health interventions. And so I'll introduce our speakers here in just a moment. The next slide, you'll see our agenda for today, and more information about our speakers. We'll be hearing from Dr. Ricardo Basura Davila, who is one of the leaders of this new, one of our new research projects examining housing for health, assessing cross-sector impacts of permanent supportive housing for homeless high users of health care. And so we'll be hearing from Ricardo about the design and rationale for this new study. And we also have the benefit of hearing from some important commentaries, additional folks who are with us today to comment on this research and its value. And our commentaries for today will be coming first from Dr. Amy Schwartz, who is a member of the National Advisory Committee for the Systems for Action Research Program. She's actually chair of our National Advisory Committee. So she's been instrumental in helping the Foundation design this new program and select the initial constellation of research projects that are part of this new program. So we'll hear from Amy, and then also from Corrin Buchanan, who is director of the Diversion and Reentry Housing program for the Los Angeles County Department of Health Services. So we're glad to have both Amy and Corinne with us to provide commentaries about this research and where it might lead us. So before I turn it over to our speakers for today, I guess for those of you who may be a bit new to the Robert Wood Johnson Foundation's research programs or to our Systems for Action research program in particular, I wanted to just start us off by giving you a little bit of an overview about this this new program. And again, this is one of three new research programs that the Foundation has launched over the last year as part of the Culture of Health action framework that has been developing over the last several years. So the Systems for Action research program in particular is charged with producing evidence on how to best align delivery and financing systems for public health services, for health care and medical services, and for that larger constellation of social and community services, aligning the delivery and financing systems across those sectors in ways that can improve population health and well-being, and in ways that can reduce health disparities. This research program builds on the Foundation's past work in the fields of public health services and systems research, as well as in the larger field of health services research. And this program really provides us with an opportunity for expanding that research lens even wider to examine not just health delivery and financing systems, but looking at the delivery and financing systems for that larger constellation of services and supports that influence health and well-being. And so again, through this program, we're supporting research studies to give us evidence on how to better align and integrate those services across the continuum of healthcare, public health, and social services and supports broadly defined. again, lots of potential sectors and services that are relevant to the research that is now underway through the Systems for Action program. Again, certainly services and financing systems in the health sector, but also in many other sectors that are relevant to health and well-being and relevant to social and economic and environmental determinants of health. In terms of mechanisms, all of our research studies are examining specific mechanisms for aligning and integrating delivery and financing systems across those sectors. And these can be organizational, institutional mechanisms, forms of partnerships and alliances. These mechanisms can involve information and decision support structures. These mechanisms can involve new technology. They can involve human capital and the workforce, and potentially lots of other strategies for achieving alignment. As part of the research program, we have a number of different research mechanisms that we've put in place over the last year in standing up this program. We have a group of 3 collaborating research centers that are across the country that are helping us produce this research and build this evidence. One based at the University of Chicago, one based at Arizona State University, and a third based at Indiana University, Purdue University, Indianapolis. Each of those 3 collaborating research centers are kind of focusing on a component of the Systems for Action research agenda and conducting research in those areas. We've also funded, most recently, a group of individual research projects, 4 individual research projects that have been selected through a competitive call for proposals at this stage. In today's webinar, you're going to be hearing from one of those 4 research groups funded through the individual research project program of this initiative. And then again, our group here at the University of Kentucky functions as the national coordinating center for this effort, working with the collaborating research centers and with the investigators that are part of these individual research projects to help us build this new body of evidence. And I should have mentioned earlier, we do have a research agenda that kind of describes the landscape of evidence that we're seeking to produce through this program that you can access on the Systems for Action website. We certainly encourage you to do that, and we encourage you to reach out to us as you have ideas or interests related to this body of research. So without further ado, let me turn it over to our first speaker again, Dr. Ricardo Basura Davila, who is one of the leaders of this new research program. He is a health economist at the Los Angeles County Department of Public Health and director of the Policy Analysis Unit there at the LA County Department of Health. He's worked in fields of public health services research and public health economics research for a number of years now, focusing in on economic evaluation and quantitative policy analysis of a variety of public health and health programs and policies, with a special focus on using advanced methodologies for estimating health and economic effects. So we're excited about this new project and excited to hear more about this new study from Ricardo. So let me turn it over to you, Ricardo.
Thank you, Glenn. Good morning. Well, at least good morning still here in Los Angeles. First of all, I'd like to thank the Systems for Action program for the opportunity to tell you all about our study, and also, of course, the Robert Wood Johnson Foundation for the financial support that is making the project possible. This project is being led by the Los Angeles County Departments of Health Services and Public Health, but as you'll see in a few slides, it also involves a partnership with a few other agencies, and we believe it is relevant to various different systems within the public sector. Let me start by discussing briefly the significance of homelessness in Los Angeles County. In 2015, the county had the largest local population in the United States of homeless individuals and chronically homeless individuals. And the difference between these 2 groups is chronically homeless is an individual who has a disabling condition and who has either been continuously homeless for a year or more, or who has had at least 4 episodes of homelessness in the past 3 years. So there are individuals who clearly have issues that are preventing them from remaining housed. And as you can see on the left on the slide, LA County accounts for 7% of the homeless individuals in the U.S. and twice as much the share of chronic homeless individuals. And considering that our total population is only 3% of the U.S. population, then evidently this is a serious issue in the county. Not only are the numbers high, but also in the last year for which there is data, LA County experienced the largest increase in the number of chronically homeless in the United States. As you can see on the graph on the right side, in the U.S. Over the current decade, although slowly, but the number of homeless individuals has been decreasing overall, whereas in Los Angeles County we have experienced the opposite trend. The numbers have continued to increase, and particularly the last year of data, there was a very significant steep increase in the number of homeless. And I should mention, because some numbers later on will be larger than this, these are estimates for the number of homeless at any given night. Because this is a very dynamic problem, the total number of individuals in a year that experience homelessness is much larger than this. So why do the Departments of Health Services and Public Health even care about homelessness? Well, there's plenty of evidence that homeless populations are at higher risk of acute and chronic illnesses, mental health disorders, and experience higher mortality than the regular population. Moreover, they experience significant gaps in access to health services, and because they're heavily reliant on emergency department visits, and they have high rates of hospitalization for preventable conditions, then these populations impose a pretty significant burden on the healthcare sector, and in particular in the publicly provided healthcare services. But homelessness is not costly only to the healthcare sector. It's actually costly to several other systems in the public sector. This table summarizes findings from a report released earlier this year by the Los Angeles County Chief Executive Office. And they used unique data, which is actually very similar to the data we're going to use in our study, that had linked administrative data for several county agencies that allowed to identify unique individuals that receive services from many departments. And they looked at the total cost to 6 different agencies on services provided to homeless individuals. And I guess the punchline is on the next to last row. As you can see, in fiscal year 2014-15, Los Angeles County, these 6 LA County agencies spent nearly $1 billion in providing services to the homeless. And they served nearly 150,000 individuals who experienced homelessness at some point during that year. Moreover, if you look at the last row on the table, the higher utilizers, the most costly 10% individuals, accounted for more than half of those expenditures. So this roughly 15,000 individuals received services that cost the county nearly $500 million. And the average cost for higher utilizers was 5 times the cost of the average homeless individual. So we're talking about a very significant burden on the public sector imposed by homelessness. So in 2012, the Department of Health Services created the Housing for Health initiative. This program provides permanent supportive housing and rental subsidies to homeless individuals who are high utilizers of DHS services. And by high utilizer, it basically means that they had 2 or more visits over a 12-month period. And another requirement is that they should be suffering from other significant comorbidities, medical conditions. The objectives of Housing for Health are to reduce homelessness, to improve health outcomes among homeless individuals, and to reduce the inappropriate use of expensive healthcare resources. The program, like I said, was created in 2012, but the first person housed by the program actually received their home in 2013. And the program has been growing really fast. In December, as of December of last year, they had roughly 1,200 clients housed, and they expect the number to grow to 3,000 by the end of this year. And the goal over the next 5 years is to provide 10,000 units for their clients housed through the program. This simplifies the representation of the Housing for Health client process. Referrals are made by health services facilities and also some of their clinical partners. There is an assessment for eligibility, meaning the eligibility criteria of the program. And for those who do not meet it, then that's basically where it ends for them, although of course they're referred to other services if applicable. And those who are deemed eligible for the program, there's also a second assessment of whether they need rental subsidies. And this is important because many of these clients, even if they qualify for the program, then they also need to secure some being able to pay rent. And some of them qualify for federal subsidies, but some of them do not. And Housing for Health has its own program, the Flexible Housing Subsidy Pool, to provide subsidies for those who do not qualify for federal programs, and if they need it, so that they are able to secure housing, whereas otherwise it would be a much more complex process if they didn't have this option available for their clients. In the end, everybody who is qualified for the program, and when there's of course room available, they are referred to receive permanent housing, and they also receive supportive services, which are key because they help individuals get connected to benefits and services in other sectors such as substance abuse treatment, job training, welfare programs, etc. And the whole purpose is to stabilize their lives. And they have very intensive case management services to help them stabilize their situation, and so that they are able to remain housed, they're able maybe to find jobs, deal with healthcare, mental health issues that they have. So there are a few aspects to Housing for Health that make it unique. First of all, by focusing on high utilizers of healthcare services, the program is aligning the goals of at least those two sectors, healthcare and housing. To begin with, they're trying to reduce inappropriate use of health services by these populations and by providing them housing. But because high utilizers of DHS are also likely to be high utilizers of services in other sectors, then they're probably aligning the goals of several other public sectors in Los Angeles County. Housing for Health also reduces fragmentation in the delivery of supportive services. There is a centralized contracting process with the service providers, and there's very intense oversight. They send the program weekly reports of their activities, the linkages the clients have been making, and the program actually reviews those reports, and they provide oversight to their service providers, making sure that they're doing what they're supposed to be doing, which is different than your typical permanent supportive housing model, where the oversight is certainly not this intense. And the program also reduces fragmentation and uncertainty in financing mechanisms, because housing, supportive services, and rental subsidies, all of them are financed through the DHS General Fund. Then once someone gets in the program, there's no uncertainty on whether they'll be able to pay for rent and trying to get rental subsidies for their clients. The process to provide them with housing is much more streamlined when it comes to Housing for Health than to the more typical permanent supportive housing programs. So permanent supportive housing is not really a new approach. It has been around for decades, and there have been plenty of studies of its effectiveness. And so, the studies have found that this approach to providing housing increases housing stability. It has many other benefits, such as reducing the use of shelters, acute healthcare services, hospital admissions, hospital length stay, and even incarceration. Why is our study then necessary? Well, there are still some limitations to the existing evidence that we're trying to fill in. Most studies in the past have focused on the impact of permanent supportive housing on single sectors, such as studies looks at only how it affects healthcare or how it affects criminal justice. Now, more recently, there have been some studies that use administrative data linking service utilization across sectors, similar to the data we plan to use. But those studies in general have mostly compared permanent supportive housing clients to individuals who did not receive housing, which of course is important. It's the first step in creating the evidence base for a public program. But I think now one interesting question is whether Housing for Health's unique approach in the way it's more structured differently than other programs, whether it has any benefits in addition to those created by regular permanent supportive housing programs. And moreover, most previous studies have not explored the dynamic aspects of this type of program. It is very likely that by linking their clients to services in the healthcare, social services, substance abuse, etc., there are significant spillover effects and synergies created by Housing for Health, so that by creating housing and affecting healthcare, then those are going to have additional spillovers into other sectors. And there can also be significant feedback effects. So if you improve somebody's health and that in turn allows them to seek employment, that may also have an additional impact in health, creating this positive feedback loop that our previous studies have not explored. So how are we trying to fill in these gaps? Well, these are our research questions. First of all, obviously the questions important for the program. Does Housing for Health achieve its goals by improving health outcomes for its clients? Does it improve the quality of healthcare received by the clients? Are they transitioning from acute care services to preventative services using DHS more as a medical home? How does the effectiveness of Housing for Health compare to other permanent supportive housing programs? Is this a model that maybe others might want to start trying to adopt? And then come the questions that also obviously are more relevant to systems for action. How does Housing for Health affect service utilization and cost across public sectors when compared to other public permanent supportive housing programs? So we want to focus not only on one or two sectors, but on a variety of public systems to understand interactions. And by going to those interactions, do these client linkages to other sectors create any synergies, thus improving system-wide outcomes and lowering costs in the public sector? So the data that we are going to use for our study, first of all, we benefit from using the Enterprise Linkage Project. It's an integrated data system created by the Los Angeles County CEO that has service utilization data from several LA County agencies, and we're going to use the data for these 6 agencies that is already available in the ELP. We're also going to use administrative data from Housing for Health and from other permanent supportive housing programs, more demographic and socioeconomic information from the clients. We're going to use electronic health records from DHS to look at health outcomes and quality of care indicators of the care received by these populations. We're also going to conduct a survey of benefit eligibility for Housing for Health clients and clients of other programs to be able to assess whether they were linked to most services or all the services to which they were eligible. And finally, we're going to collect qualitative data through focus groups and interviews, and I'll describe our analysis in a couple of slides. This is just a simple representation of the linkage process we're going to use. The administrative data from Housing for Health and other programs, electronic health records from DHS, and the data from the Enterprise Linkage Project, all of it is going to be available to staff of the Los Angeles County Chief Executive Office. And they have a probabilistic matching algorithm to be able to link individuals across all these different data systems, and they're going to run that algorithm. They're going to de-identify the data set, and that is the data set we're going to receive. So those of us doing the analysis will only have access to a de-identified data set, but that will be linked across all these different other files, and will allow us to look at individuals longitudinally over a period of since 2012 through 2016. We'll be able to follow them as through the different services they use, the cost of those services, and also the health outcomes and housing outcomes. So we're going to use a mixed methods approach for analysis. First, our quantitative analysis. We're going to use propensity score methods to create a sample of all Housing for Health clients, and then a matching comparison group. Those will be non-Housing for Health clients, but who have similar characteristics to the clients of the program. This will allow us to eliminate some of the biases that I'm sure most of us participating in the webinar understand can be created by trying to evaluate programs using observational data. To further eliminate other potential biases, we're going to do a difference in difference analysis. Our data period will start roughly 1 year before Housing for Health was created, and so we'll have data from before the program creation for all of the individuals in our sample, and we'll be able to then do difference in differences, which basically does comparisons for before and after the treatment for both the treatment and control groups. And finally, something I'm particularly excited about, we're going to follow a participatory simulation modeling process in which we're going to involve various stakeholders in the housing and other sectors to develop a simulation model of how housing provision may affect service utilization and outcomes on all the sectors represented in our data. The stakeholders will be involved through a period of several probably months to develop the simulation model, and then we're going to populate the model's parameters using the data. Like I said, it's a mixed method approach, so we're also going to be conducting qualitative analysis. We plan to hold between 4 and 8 focus groups, including Housing for Health clients, Housing for Health service provider staff, and then also clients of other permanent supportive housing programs and the service provider staff of those other programs to better try to understand how the programs are different in their approach and whether any difference we find in the quantitative analysis and outcomes or service utilization, try to understand where those differences arose from. We're going to conduct semi-structured interviews with key informants, including senior staff, Housing for Health and other programs, and at the agencies represented in our data, such as the DHS, the Department of Public Social Services, etc. The qualitative analysis, the data will be analyzed by 2 independent reviewers, and also we'll do content analysis by using appropriate software for this type of analysis. So if everything goes well, we're hoping to get a deep understanding of the pathways and processes that you see in this hypothetical representation of a model. We hope to have a simulation model with a similar, with a structure that will look something like this that we'll be able to populate from our study. We want to understand how providing housing, the spillover effects, the impact it has across many other different sectors, such as criminal justice, social services, healthcare, how it affects the cost, how it affects outcomes in these sectors, and also the feedback loop. So if we improve somebody's health, does that have some effects that eventually come back and cause further improvements in health? And of course, there may be some negative impacts. It is likely, for example, that social services agencies will see their costs increase because the Housing for Health clients are being linked to their services. This is not necessarily a bad thing, but it would be useful for them to know if they can expect further increases due to expansions of the program. So we'll try to look at that as well. The significance of the study, we hope that our findings will help us first assess whether the program is achieving its goals of improving health and reducing unnecessary use of healthcare services. Furthermore, we want to understand the spillover effects and the synergies created by providing permanent supportive housing to homeless populations. And something I think is very important is we will learn whether there is a financial case for similar programs that would make them sustainable. If the program achieves its goals and it indeed reduces costs to DHS in the long run, then that clearly makes a case that DHS should continue supporting and maybe growing this program, because overall it will eventually continue saving them money. But there may be also a case for other agencies. If other agencies benefit from the program, then there might be the opportunity to cross-subsidize the program by having other agencies invest on it, knowing that it will eventually benefit them financially. And for those agencies who do not benefit from it, then there may be also further cross-utilization that maybe DPSS will need to receive some additional support to be able to provide the additional services that will be required by the implementation of the program. So this is a summary of the milestones. Obviously, we kicked off already a month and a half ago. We expect to receive our first data set, the linked data, early next year. to begin doing that analysis. Also, early next year, we'll begin our qualitative data collection. I'm not going to go through all the rows, but in short, we'll begin our simulation model in the middle of next year. We're hoping to conclude our analysis in the first quarter of 2018, and if all goes well, by June of 2018, we will have our deliverables, including the final report, policy brief, and at least one manuscript written reporting the findings of our study. Thank you so much for your attention. My contact information and that of Corinne Buchanan, who is our co-PI, are in this slide. Feel free to contact us if you have any questions that are not addressed in our webinar today. Thanks.
Fantastic. Thank you, Ricardo. And I'm sure that that tour through your study has generated some interesting questions from our participants today. But and we encourage you to think about those questions. You hopefully, if you're with us on the online webinar portion of today's event, you can see the chat box there where you can type in your questions or comments that, and we will have time here shortly to get into some of those issues. So we encourage you to use the chat box first of any questions. Before we get to that, though, we do want to hear from some commentaries from two other people who are with us today. We're first going to turn to Dr. Amy Schwartz, who I mentioned earlier is chair of the National Advisory Committee for the Foundation Systems for Action Research Program. And she is, her day job is as the Daniel Patrick Moynihan Chair in Public Affairs and the professor of economics at the Maxwell School at Syracuse University. And she also holds the faculty position as a professor of public policy, education, and economics at NYU and director of the Institute for Education and Social Policy there. So we're pleased to have Amy with us to provide some commentary first off the bat. So, Amy?
Well, thank you for having me. I'm delighted to participate and to hear about this really exciting work. And let me be clear, I think it is very exciting, and so I'm going to try to be brief and tell you why I think it's exciting and what's important, so that we have some time to hear some questions and continue to discuss. So the first reason is that this is an important problem. The problem of homeless adults is stubborn, it is persistent, and it is costly, both for the individuals, but also for society and for the public sector. In this project, they are picking up a particularly difficult piece of it, but a theme I want to keep coming back to is that it is the tip of the iceberg. I mean, these are a very hard part of the homeless population, but homelessness also extends to and affects the lives of children, of families, and it has a different nature, but it's you got to pick up the stick someplace, and it's really exciting to see it being picked up at all. So let me start by saying how important this work is and how delighted I am that they are undertaking this work and that the foundation is funding it. So as you saw in the presentation, and it's probably heard before, the causes of homelessness are complex and multidimensional, but so too are the consequences. And that's been a problem for trying to figure out both what to do and what is the efficacy of interventions. Many previous research projects have tried to look at a narrow slice, an impact of an intervention in one dimension, trying to weed out all of the other things. But I think what's exciting here and important is that it's trying to look at them together as a system, so that the impacts in one dimension are understood as affecting other dimensions, and that there is a reverse effect, a feedback loop. So trying to understand this vortex is critical, and it does mean taking on a very hard research problem. So some of the problem of research, of doing this kind of research, is getting the causal story right. And here they've tried a nice set of things, the propensity score matching, the samples, but we should acknowledge this will always be a difficulty. Doesn't bother me in the sense that I think if we are moving forward and advancing our understanding, then we will slowly learn more and more about the causal mechanisms. But because of that difficulty, it's been hard to fund this research. So again, I think this is an exciting thing about the entire Robert Wood Johnson agenda, which is to tackle this hard problem, provide funding, even in a case where isolating this specific causal mechanism is going to be a challenge. Another really important piece is the exciting data they're putting together here. Trying to link these data across agencies and have different agencies work together as partners in this is, it's a problem. Difficult issues about identifiability of data, about privacy, about sharing, about playing well together. And so I want to say an exciting thing about this is that I also feel this project is laying the foundation for future work because those partnerships, once formed, can be built upon and expanded. And this seems to me extremely promising. Something I would say I will look forward to is the next step at some point is going to be to look at homeless families and children. The link to educational outcomes and health problems for children are severe and important to do for the future. That's not a criticism of this study. In fact, it's the opposite. It's I want to say it's a compliment. I think once you solve this and you have these connections, there's plenty more to build on and more to do. And this is a great foundation. So I'm looking forward to hearing more. Oh, sorry, I did have one more point. Interesting to think about the costs of this and the financial case for it. And I want to say there are two again. One is about the business case from the point of view of the local public sector. Can we save money? Can we do better with our money? That's important. But we don't want to let go of the cost to these individuals. People are experiencing homelessness and the health problems that are connected to those, and that's a big cost too. So interested in continuing the discussion.
Fantastic, Amy. Thank you so much for those comments, helping us put this new study in context in terms of its importance and where it's likely to contribute, and also some of the challenges that are inherent in this work. We also want to hear from another bit of commentary from Ricardo's co-PI on the study, Corrin Buchanan, who he mentioned earlier. Corrin is works in the sister agency, whereas Ricardo is based in the Department of Public Health, LA County. Corrin is based in the Department of Health Services, a sister agency, which I believe there's a process underway for bringing those two departments together. That's another interesting side note here. But Corrin leads LA County's Diversion and Reentry effort to provide housing and services to end homelessness for individuals specifically who are justice involved. So obviously highly relevant to the intervention being studied here. She works with the flexible housing subsidy pool there in LA County, and works on a number of other issues, policy and planning issues around housing for these populations. So welcome, Corrin, to add some additional commentary about this new study.
Hi, thank you so much. So again, I'm Corinne Buchanan. I'm with the Department of Health Services, and I'm really pleased to be on the phone with you all today, and also pleased to be involved in this important study because I work for Housing for Health, which is the division that is the subject of this study that we're undertaking. So I thought Ricardo mentioned sort of why it is the Department of Health Services is doing this housing work, but I thought I would touch on that a little bit more. So people often say, well, you provide health services, so why is it that you've gotten involved in housing for your patients who are homeless? And we do that for two main reasons. our first and foremost reasoning is that we know that permanent supportive housing improves the health outcomes of our most vulnerable patients. This is something we believe in deeply here at the Department of Health Services in LA County. We believe that housing is so important in improving the health outcomes of our patients that it's something that a doctor should be able to write on their prescription pad. It's what it takes to help our patients actually become healthy and well. And then, of course, we also do this work, as has been discussed previously on the call, because we know and we believe that permanent supportive housing leads to better cost savings and better alignment of resources as a public entity. So we do that for those two main reasons. We, in our programs thus far, have served over 2,000 individuals since our launch in 2012. And we have a 96% 12-month housing retention rate, and we are really proud of that figure. National average usually hovers anywhere between 85 to 90%, so we're really proud of our 96%. We think it's a testament to the incredible service provider partners who we contract with. So these are community-based organizations who really embody a whatever it takes approach to help our participants get into housing and then maintain their housing. So I'll talk a little bit about how our services are a little bit different. I think that from other permanent supportive housing projects, and Ricardo also touched on this, but we are really focused on health and social wellness for our participants. And what that looks like on the ground is making sure that all of the participants in our program, in addition to being connected to housing, that they're also connected to a primary care provider, that they're also connected to community-based mental health services, that they are connected to substance use disorder treatment when appropriate, that they are connected to any income benefits for which they may be eligible, things like Social Security disability insurance. For participants who are interested in returning to the workforce, it's helping people get connected to employment opportunities. And I think what's also really important about our approach is that all of our case management staff and the housing navigators are focused on helping our participants to create their own client-driven, individualized service plans, so that each plan is really tailored to the needs and desires of our participant population. So I want to move on to how this evaluation will help us understand our programs and understand the impact of permanent supportive housing. And I'll start by saying about how thankful we are to the Robert Wood Johnson Foundation for the opportunity to look more deeply at these study questions. In particular, we're excited about how this program or this study will actually help us to make program and policy improvements in our own programming, help us to understand what's working and what's not, in particular where the positive impacts are flowing from for our particular patient population. We're excited to understand how our programs, the outcomes of our program might differ from other permanent supportive housing programs in Los Angeles County. And the question really is if our health focus, health and social wellness focus, is leading to different types of outcomes for the participants in our program. We have a couple of unique programs in Los Angeles County. One is a locally funded rental subsidy, and Ricardo touched on this just briefly, that we have a program that we can use to serve people who may not be eligible for a federal subsidy. So that includes people who are undocumented or people who have a criminal record that makes them ineligible for a federal subsidy. So we're curious to know how this unique program has helped us to reach our goals in Los Angeles County. And then very importantly, we want to know how housing impacts other sectors, the mental health sector, the substance use treatment sector, really importantly, the criminal justice sector. There have been other research studies that have looked at how permanent supportive housing might impact the criminal justice costs that a locality incurs. So we're really interested in understanding how our program has impacts across those other sectors. We hope to be able to use the results from this study potentially to expand our programs here in Los Angeles County. So certainly when we know if a program is working and if we understand how it's working, that helps us if we can put that study in our back pocket when we're going to our local board of supervisors and seeking additional funds to be able to expand a program like this. and also because we're excited to be able to build the national body of research that sort of understands how permanent supportive housing impacts this very special and vulnerable population of individuals who are experiencing homelessness. And the numbers here in Los Angeles County are quite staggering. So we're excited to be able to demonstrate a model that really works to help address that problem and help participants in our community get into a home of their own and begin to improve their health outcomes. And I think with that, I will turn it back over.
Fantastic. Thank you, Corinne, and again, thank you to Amy and Ricardo for your comments on this very exciting new study. So we do have some time for questions from our participants today, and we invite you to use the chat box, type in questions, comments that you might like to surface, and we'll get to as many of those as we can in the next 10 or 12 minutes. And I'm going to ask my colleague Ann Kelly, if she could read those any questions we have in the chat box, because I'm not able to see them from where I happen to be at the moment. So, do we have any that are in the queue?
Yes, we do. This is Lisette. We actually have quite a few questions, so I'll just start off. How is the data accounting for individuals who require hospital or in-home care, such as in a medical respite or recuperative care center, rather than directly into PSH?
This is Corinne. I can answer that question, Ricardo, if that's okay.
Yes, of course. Good.
So we do track in-home care services for our participants in our program through our own administrative data here at Housing for Health. And then we also operate, you mentioned recuperative care. We do operate recuperative care housing through our program as well, out of our office at Housing for Health. So that also is included in our administrative data. I think they are very important pieces of information because it tells a story about how participants might flow through our program. Oftentimes, individuals are coming directly out of a hospitalization. We then can move that individual into a recuperative care setting. We want them to be in a setting that's the most appropriate fit, and in many cases the hospital. They no longer need to be in the hospital. If that person were not homeless, they'd simply be referred to their, the welcoming arms of their family and their own home, but because they don't have that option, we are able to move them into a recuperative care setting. And in terms of in-home supportive care, the goal is to access in-home supportive care for any person in our program who may be eligible for those services. So definitely something we keep an eye on.
Great. Next comment.
Here's another excellent question. Can you please describe some of the mechanics of working with multiple administrative data sets, linking the data and the algorithms that you will develop? How are you managing HIPAA? And also, once you develop these methods, are you willing to share these with other state agencies?
Okay, I'll take that one. I think answering this question could be its own full webinar. Evidently, it's not an easy thing to work in linking administrative data sets from different agencies that use different data systems. Even within the county, there's pretty wide variation in the data we use, and definitely lack of compatibility. I would say we're very lucky. We benefit from an effort started by the Los Angeles County Chief Executive Office several years ago in creating the Enterprise Linkage Project. It's an integrated data system where they already developed the algorithms, the necessary memoranda of understanding, and the data sharing agreements, et cetera, with all these different agencies to receive the data regularly. I'm not sure if it's monthly or with what frequency, but they receive the data from all these agencies in a standard format with identifiers, and they are the ones already linking the data on a regular basis. They already took care of whatever legal regulatory issues that needed to be done. We'll have to do some ourselves. The question includes asking how we're managing HIPAA, because the ELP, the Enterprise Linkage Project, does not include the data from electronic health records, so we're going to be adding it into our data set. So we're requesting a HIPAA waiver from our institutional review board, and the idea is to be able to utilize some of health indicators, some quality of care indicators from DHS electronic health records in our data set. In terms of the methods, the algorithm, I am afraid I do not have the exact details of what specific methods they're using. I see there's another question by someone else who asked if we could share the probabilistic linkage program with others, because it is not, I do not actually have it. I have not even seen it, so I'm afraid I cannot answer the question, but it might be possible. I don't see why a linkage algorithm that I don't believe it's proprietary could be shared, but I'll have to consult our colleagues at the LA County Chief Executive Office on whether that'd be possible. So what I would say is there are obviously all kinds of roadblocks and issues in undertaking a project that requires this much data from so many different agencies. Those of us interested in learning more about how we're doing this, please feel free to contact me, and I will try to find out more info about how this has been working with the ELP, and how we're going to be dealing with these issues and building our data set with the additional information that has to go into creating our own data.
Thank you.
Excellent. Thank you, Ricardo.
Thank you. And then another question is, our findings over time have found that chronically homeless individuals whose health is compromised become sicker and health costs rise after a couple of years as they get treatment. How to account for that in the decrease in costs starts to rise dramatically? Will the control group who does not get as much care become less expensive even if they don't live as long?
Thank you. This is a great question, and I want to also look back into a comment made by Amy Schwartz regarding the financial case. Well, first of all, I think we benefit from having several years of data. Reading the question, it says that that individuals' health costs rise after a couple of years as they get treatment. We'll have more than a couple of years of data. I think for the good number of people will have even at least around 4 years of data. So hopefully, if there's a significant increase in health and appropriate use of services, we might see maybe a rapid increase in costs early on, and maybe we'll see that it goes down. I'm not sure. That's why we're doing the study. But even if we don't, Amy made a very good point, which, on the one hand, we have the business case for a program like this that seeks to reduce inappropriate use of healthcare services. But, I'm sure the main goal of the program is to benefit the clients of the program, to improve their health, improve their outcomes. And even if at the end of the day, the business case does not quite arise from the data, there is still value, I think, in having people being healthy. My background is in economics. I still think of myself as an economist, and we often get a bad rep for focusing too much on money. But actually, I think something economists have understood for quite some time when doing economic evaluation is that not everything comes down to dollars. There is intrinsic value in a person being healthy, living a more complete life. And even if at the end of the day we find that the program's benefits improve health and well-being, but do not necessarily reduce costs, I think we'll be able to see beyond that and understand that there is value for all these people, the thousands of clients of Hospital Health, from being in a better situation. So we'll be looking into financial costs, healthcare costs beyond those 2 years. But we also understand that there's much more to this than just a business case for the program.
This is Corinne. I'll also add that our program really focuses on our highest cost, most frequent users. So even if we see an increase in primary care or other treatment costs, in the majority of cases, the decrease in those extremely expensive emergency costs is greater than the increase in the more preventative medicine costs that we see after someone's housed, because of our targeting to our most costly individuals across our system.
Thank you for that. Another question is, what is the role of the probation and sheriff sectors data in the project?
That's a good question, and I'm not sure I can answer it.
I can answer that one.
Go ahead,
so many of the participants, homelessness and incarceration are mutual risk factors, and homelessness and recidivism are mutual risk factors. So that's one of the biggest, when you look at the cost of people who are homeless, the biggest price tags are, number one, healthcare costs, and number two, criminal justice costs, because these individuals also get stuck in sort of an unvirtuous cycle in the criminal justice system as well. So one of the places where we've seen cost savings in national data around permanent supportive housing is that criminal justice sector. So we're really interested to understand what the data demonstrates here in Los Angeles County. What are the criminal justice costs before someone's in housing, and then what are the criminal justice costs after someone has entered permanent supportive housing? And we expect to see a strong decrease there.
Yeah, and I guess the only thing I'd like to add to that is that obviously the idea is to look at whether the program is affecting arrest or probation outcomes, etc., in the data. I was a little reluctant to answer it because we do not yet have the data in our hands, and there's not a lot of documentation on what we'll actually have available, so we have a rough sense. We know that service utilization in general and some arrest information will be available to us, but I cannot tell you yet what exactly we'll be able to do until we have the data in our hands, so we know exactly what variables will be present on it.
And I can just say that the sheriff's data includes basically booking data and jail days, and it also will be able to it'll tell us what type of custody setting someone is placed in. So if someone's just in the general population jail, there's a certain cost associated with that jail day. But if someone's in a high observation or a mental health housing, the costs for those particular custody settings are much higher, and so we're interested in understanding how we can reduce those costs in particular.
I think we have one more question. Do you have legal partners to assist you with things such as public benefits and disability benefit appeals?
This is Corinne again. So we do. We have a program that's focused on benefits advocacy here in Los Angeles County. So the goal is we have a team that collects medical records. So because Department of Health Services is the large public hospital system and the large public healthcare delivery system, we have an incredibly valuable sort of treasure trove of data that would allow us to create disability benefits claims that are quite robust and help the Social Security Administration evaluate whether our clients are eligible for disability benefits. So collecting those medical records and completing the benefits applications is a big part of what we do to help our participants get access to those really important benefits.
Fantastic. Thank you again, Corinne and colleagues for this webinar today. And hopefully this has stimulated your interest in the study. We're actually hearing about the study at the very front end as the study is just in the process of getting underway now. And that's the purpose of these research in progress webinars that we do through the Systems for Action program, is to provide opportunities for periodically for researchers who are leading these studies to update us about emerging findings and